Okay, welcome to our Q&A with Lara Briden, a naturopathic doctor who's the author of the Period Repair Manual. So we're just going to get started with some questions that were sent in early. So the first question for Lara was, what do you think about eating for each specific phase of the cycle?
Thanks, Lana. I'm happy to be here with you and everybody. That's an interesting question. I'll just preface my answer by saying I don't do that for myself or with my patients. And that doesn't mean that I'm against it. I think in theory, yes, there could be some value, for example, in eating during the times in our cycle when we have high estrogen. There might be value in sort of bringing in foods that help with the natural detoxification and clearance of estrogen. But beyond that, I just haven't myself seen the value of that. I think one thing I'll say is that a lot of, like, for example, one of the most important events in our cycle is progesterone production. And that's actually put in motion months before, like weeks before. That's something we're moving towards in terms of our total nutritional status and total health for months. So, I don't really think it's possible to, in fact, I think the first part of the cycle is actually probably the most important for progesterone production, because that's when we're getting ready to have a good quality ovulation, and that's how we make progesterone. So I don't really see the need to, eat differently specifically for the estrogen and progesterone phases of our cycle.
Okay, just a follow-up question. What about exercising for each phase?
I think the truth is, I guess I don't do that myself. I don't use that for patients. I think that I'm open to ideas about that. I think there could be some value in that. Certainly, I think, I think it's smart to probably change. I do think it's probably a good idea to have maybe slightly less vigorous exercise during the heaviest days of the bleeding. But I'd be open to, I hope me to learn about some of that at the Blood Cycle Conference myself, some of the value of, that eating or exercising differently for the different phases of the cycle. It's not something I've done. Yeah.
Okay, great. So to anyone who's joining us, just type in your questions in the Q&A on the side and we can take your questions. And you can do that throughout the whole Q&A today. So before that happens, though, we'll just continue with the questions we had taken in. So the next one was about transdermal magnesium. So if you're taking a supplement, what do you think about taking it transdermally through the skin?
Short answer is I'm now convinced that there's value in that. For the longest time, I just didn't think so. And even on my magnesium blog, which is a very popular post on my blog, there are lots of questions about transdermal. And finally, I was able to kind of look at some of the research and some of the formulations and determine that, yes, there can be a substantial amount of magnesium coming in through the skin. But I think it depends on the product. And I don't think it's enough to just casually say, oh, this is a magnesium oil. Therefore, I think it's important about trying to get some answers from the manufacturer about how many milligrams are contained in that, and what, their evidence shows, like what percentage of that would be absorbed. We need to have a therapeutic dose of magnesium is at least 200 or 300 milligrams per day. So if there's a formula that promises to deliver that much transdermally, then yes, I think it can be beneficial. And the advantage of it, I'm sure your listeners know this, is because depending on the health of a person's digestion, some people find magnesium quite laxative, that it can cause loose bowels and diarrhea. And so a transdermal formulation is one way to get around that. But another thing I'll say is it's also important just to have a healthy digestion. So if magnesium is triggering loose bowels, then that's actually a problem with the digestion. So that can be a cue that something needs sorting out there, and so that you can tolerate an oral magnesium. And some magnesium formulas are better than others, like magnesium oxide, magnesium citrate. Those are the most laxative forms of magnesium. There are other forms like magnesium glycinate, which are less laxative and easier to tolerate.
Okay, good. Thank you. I just see a question from Radhika. So she's just asking, are we currently live with you? So yes, we are. So
yes.
Welcome, and ask any questions you might have, okay?
We're live.
Okay, so next question we'd collected beforehand was, why am I so emotional when I've missed some periods and my period starts again?
Yeah, and I take that question to mean, I guess, when during when the bleeding actually starts again, or I assume that's what she means, or if not, the premenstrual phase again. I think, look, I think when we haven't had periods for a few months, then our hormones have been fairly steady state. It might have either been, I guess there's two scenarios I would see there. It might have either been building up to, for example, an anovulatory bleed, which we'll come back to a bit later in the questions. And there would have been quite a high estrogen for quite a long time, potentially, before the bleed finally starts. And then what we've been experiencing is a rapid drop in estrogen with the first day of the period. And that anytime estrogen goes up quickly or down quickly, we feel it. And we can have an emotional reaction to that. It's like estrogen is like a drug almost. So a rapid change causes a rapid drop in estrogen would cause probably kind of sadness or weepiness or sort of depression. The other scenario is if this is more of a premenstrual emotional change, then it could be that estrogen's actually been, after a few months with nothing happening, really flatline. There might not have been much estrogen at all for a few months. And then as you move towards either a real period or an anovulatory bleed, estrogen would be a lot higher than you're used to. And that can cause kind of an irritability picture.
Okay. All right. Good. Thanks for answering that.
Yeah.
Okay, so another person was wondering about the benefits of red raspberry leaf tea beyond relief for menstrual cramps. So can it help with spotting or ovulation or progesterone levels in the luteal phase?
I'm going to say not that I'm aware of. I don't use I do recommend it just as a tea, for prepartum, like for pre-delivery, which is it's only established use that there's some evidence, small amount of evidence that it can help to regulate uterine contractions if you take it for a couple of months before labor. But beyond that, I don't really use it. Yeah.
Okay, so what are some recommendations then that you might have for promoting ovulation or progesterone production?
Okay, that's a very good question. So progesterone production, ovulation and progesterone production are the key events of our menstrual cycle, as you know. They are an expression, ultimately they're an expression of our health. So when we have, so in my book, I talk about that, how important ovulation is and how in a way it's a report card for our health. And so in answer to what are all the different ways to promote ovulation, the short answer is to be healthy in every way that you can. So if you're not ovulating regularly and not producing a lot of progesterone, then it's going back and thinking, what are all the possible reasons that could be happening? That could be, for example, a problem with insulin, very common problem with insulin resistance that impairs ovulation and causes low progesterone, a problem with thyroid, which is also extremely common, even a problem with inflammatory foods or a digestive problem that's creating some inflammation that's interfering with ovulation and progesterone, nutrient deficiency, such as zinc and iodine deficiency. Those are common. Vitamin D deficiency causes impaired ovulation. So there's no one, there's kind of no one or two things that we need for those. It's not like ovulation and progesterone are separate from the rest of our health. They're an expression of our deep health. So that's the short answer. I guess that's the longer answer. The short answer is yes, there's also herbs like Vitex, which is quite helpful. The herb chase tree or Vitex agnus castus, which I do prescribe to promote more regular ovulation and progesterone.
Okay, and what about things that can help with spotting?
Okay, so spotting, that's having a bit of light blood show. Usually, it can happen at different times, and it can mean lots of different things. I realize that every time I'm answering, it's I wish I could just give a one question, one answer kind of approach. But spotting, it's about doing detective work and figuring out what that spotting means when it's happening, for example. So, for example, it's normal to have a little bit of like bright red light spotting directly around at the time of ovulation. That's actually not something that I worry about treating so much. That can be a normal thing that happens just with the slight drop in estrogen just around ovulation, just at ovulation. then also there could be spotting throughout the month, or spotting with sex, for example, or, and that could mean different things, including infection, for example. That could mean, which obviously you want to check with the doctor, that it can mean a condition called endometriosis, which is a very common condition that also causes pain and can cause spotting throughout the month, and spotting with sex, after sex. And then another common pattern of spotting is before the period, during the premenstrual time. And that is often from progesterone deficiency. Progesterone deficiency, one of the symptoms of that would be premenstrual spotting. So if that's something I look at, then obviously measure progesterone and see if that correlates. Look at temperatures, like the basal body temperature shift, because if the spotting is due to low progesterone, then you'll also see the fact that the temperatures are not holding, they're not elevated the way they should be in the second half of the cycle. And just a little clinical pearl, I talk about this in my book, Patient Story. I'm trying to remember the name of the patient. Oh, I've just forgotten her name. But I give a story of premenstrual spotting that turned out to be thyroid related. And that's something I see quite often because of the way we need thyroid hormone to make enough progesterone hormone. So those two things are strongly linked. Yeah.
Okay, thank you. We have a question from Radhika again. So how do we get hormonal balance for PCOS? Especially for insulin resistance. Taking magnesium and zinc helps ovulation, ?
Yep. Yeah, so that's chapter 7 in my book, Irregular Periods. And I talk about all the different reasons for irregular periods, including PCOS, which is very common, affects up to 20% of women, we think. So it's a polycystic ovarian syndrome. It's a condition of irregular ovulation and excess androgen or testosterone production. And even then, even with the diagnosis of PCOS, it can actually be due to a number of different causes. But the cause in the question, what was mentioned was insulin resistance, which is the most common reason for PCOS. Let me say the single most important thing to do before you do anything else with insulin-resistant PCOS is to stop sugar, all sugar, meaning desserts and fruit juice and sweet drinks. And that is the thing that clinically transforms the condition. That's probably more important than anything else. Second to that would be magnesium, which was mentioned, which is very helpful as well, which helps to improve insulin sensitivity and promote ovulation. It also reduces sugar cravings. So when you're trying to come off sugar, it can be really helpful to take some magnesium to be able to do that. And there are other factors too. PCOS is quite a complex condition. There are certainly lots of other nutrients that are involved. There's a genetic component, of course, and some of your listeners will be aware of that and thinking about that. There's exposure to environmental toxins, which plays a role in all female hormone conditions, but quite a strong role in PCOS. So it's about reducing exposure to pesticides and some of the phthalates and chemicals in cosmetics. Yeah.
Okay, thank you. And next question was, so what are the best initial suggestions you have for a client when they are wanting to quit the pill but are afraid of feeling awful?
Yes. And that's a very good question. And I think, because I would never like to, I hope I haven't in my blogging and my writing ever put the message out there that women should just stop the pill no matter what's happening with them. I think it is important to pause and think about the most important question is, what were periods like? What were your periods like before you went on the pill? Because that's probably what they're going to be like again, because the pill bleeds are not periods. So for anyone who's been taking the pill, say for 10 years or 15 years, the last real period you had was 15 years ago. So the pill bleeds you've been having don't give you any information about what your period's going to be like. So that's very important to understand. So if you used to have very heavy or painful periods, or you used to not have periods, for example, that might be what's going to happen again. Not in every case. I mean, you're older now, things are different, your health is different. So, but if I like to know with my patients what their problems were before. So if someone tells me, for example, another example might be that they had quite bad skin, breakouts and pimples and acne before they took the pill, or if they tried to stop the pill before, then we're pretty sure that's going to happen again. So I like to, even before coming off the pill, put in place some natural treatment for that thing, whatever that underlying issue is. And that, for treating acne, that would be coming off dairy, giving zinc, taking zinc. That's like, I talk about those in my book. And if another thing to determine before coming off the pill is if you are insulin resistant or not, and if your thyroid's okay or not. Because if you're insulin resistant, then it's important to get treatment and get started treating that right away. Like come off sugar, take some magnesium before you even come off the pill. Although one thing I'll say here is the pill actually causes and worsens insulin resistance. So you don't want to stay on the pill too long if you know that you're insulin resistant, but it's probably worth making a few changes before you come off. Yeah.
And that applies to all forms of hormonal birth control, right? Like the patch, the shot, etc., not just the pill?
Yeah. Good. Excellent, Lana. Good clarification. Yes, so that's all of those methods: injection, implant, NuvaRing, oral contraceptives. Those all work in the same way by completely shutting down ovarian function and replacing it with a synthetic steroid hormone. The only method of hormonal birth control that doesn't work in that way is Mirena IUD, or there's another one too. The hormone secreting IUDs are a little bit different in that they don't completely shut down ovarian function. So they have other side effects, but that's, in answer to your question, yes, most methods of hormonal birth control.
Okay, can you tell us more about the Mirena IUD? I remember reading in your book that it does shut down ovulation maybe 50% of the time. Yeah. So why does that happen?
Okay, yeah, good question. So that's the research I could find about what. I don't think anyone knows exactly how frequently it happens, but so the synthetic steroid that's in Mirena IUD is a hormone. Not a hormone. I don't even like to call it a hormone. It's a drug. It's a synthetic steroid called levonorgestrel. That is the same steroid or progestin that's used in a number of different methods of hormonal birth control, other methods of hormonal birth control as well. So it's not unique to Mirena. But what's different about Mirena, sorry, excuse me, is that it's local. So it's working. Its method of action is not to suppress ovulation. Its method of action is to change the uterine lining and prevent fertile mucus. And so it works locally. So it's a smaller dose. The reason that it also does sometimes suppress ovulation or suppress ovarian function is that a small amount of it goes into the bloodstream. And some women are more sensitive to that than others. The amount in the bloodstream is about 1/10 of what you'd get if you were taking one of the levonorgestrel containing pills. So that's why it does permit ovulation about probably half the months, half the time.
Okay, all right. Thanks for clarifying that.
Yeah.
So another question about PCOS, or polycystic ovary syndrome again, and inflammation. So it says that no dairy suggested. So, well?
Pardon me, I sort of missed the last part of the question. We just cut out a little bit.
So it says no dairy means no yogurt or kefir as well?
Okay, right. Good question. Good question about dairy. Now, I'll just say that I don't necessarily think that avoiding dairy is necessary for every person with PCOS. It's one of the conditions that some conditions like period pain and endometriosis, I think almost everyone basically should try coming off dairy. PCOS, it would only be certain types, kind of the inflammatory type of PCOS, where that might be a priority. Or if skin is a problem, acne is a problem, then coming off dairy is a priority. And so in answer to the question, does that include yogurt and kefir? Yes, because the problem is the protein. So yogurt and kefir are different than other dairy because the lactose has been mostly fermented. The sugar part of it has been reduced. by natural fermentation, but it still has the same, exactly the same proteins, the inflammatory casein. But fortunately, there are other kinds of milk, sheep dairy products and goat dairy products that contain different proteins that don't have the inflammatory casein. So that's an option for some women. Or you can also make kefir and yogurt with coconut milk.
Oh, okay. I didn't know that.
Yeah.
Coconut milk. Interesting. So we have another question. So I am taking metformin for insulin resistance. I have quit sugar, wheat, and dairy. Is this the normal path for recovering from PCOS? How do we restore estrogen and progesterone balance naturally? Could you suggest a few things to ovulate naturally?
Yeah. Oh, that's my book, basically. My answer is it. But yes, I will still answer it. Okay, metformin is a diabetic drug that's given to reduce blood sugar and try to normalize insulin resistance. I think has value. I certainly, some of my patients take it, and I think that can be part of the whole strategy. But I'll be honest, it doesn't work as well as some of the natural things for sensitizing to insulin. So, as I said before, the number one thing is magnesium, and the number one thing is coming off sugar, which this person has. So that will all help by improving insulin sensitivity. That will promote ovulation, and that's how you make ovulation is how you make estrogen and progesterone. So there's no separate strategy for estrogen and progesterone. It's about, if you promote ovulation, you promote those two hormones. So that's the focus. Other nutritional strategies for PCOS, which have value, is vitamin D. I can't remember if that was mentioned in the question or not. There's also a supplement called inositol or myo-inositol, which is a type of carbohydrate that's actually also found in a lot of herbal medicines like licorice. So that can be quite beneficial as well. And there's herbal medicines that are beneficial. And yeah.
Okay. And just another follow-up question about quitting sugar. So does that mean fruit and starch and those kinds of things?
No, it doesn't mean starch. In fact, when I say sugar, I'm really referring to high dose fructose, which you'd find in table sugar, in honey, in agave, in maple syrup, in dates, in fruit juice or fruit juice sweetened things. It's the high dose fructose that seems to damage insulin sensitivity or create insulin resistance more than anything else. That said, obviously there's a limit on how much starch, because starch is glucose. So starch is a sugar, it does contain some sugar as well. But it's in my thinking, it's in a different category. I think depending on the severity of insulin resistance, I might also go the next step after sugar is gone. First sugar has to be gone. Then, assess what's happening, how well the insulin is responding. Then go the next step and start to reduce starch. And it works best as a little trick, for your listeners. If you're going to reduce starch, take it out of breakfast. Remove it from breakfast. Breakfast is the best time to have more of a high fat, high protein meal. When I say fat, the two things go hand in hand. If you're going to do a low carb diet, a low starch diet, then you have to increase fat. They go together. Otherwise, it doesn't work at all. Otherwise, you just feel hungry all the time. And finally, final thing I'll say about starch is that wheat and gluten-containing products are in a different category again, because they're problematic for other reasons, not just the fact that they're starch, but because they're inflammatory, potentially that they impair insulin sensitivity because of the gluten itself, gluten's a protein, so in wheat. So there are non-gluten starches which are healthier. And I have a post called The Gentle Carb. I talk about gentle carbs being, potatoes and starchy vegetables and things like that.
Okay, thank you.
Yeah.
So now we're just going to move on to the question about anovulatory bleeds. So how can you have a period if you don't ovulate, assuming you're not on hormonal birth control?
Yep. Okay, good question. Well, the bleed, it's just So a true period, what I define in my book as a true period, is one that follows the proper cycles of follicular phase, ovulation, and luteal phase, where you make progesterone. That's kind of how you define period. An anovulatory bleed means there has been no ovulation, no progesterone. There's only been estrogen. There's only been an attempt to ovulate by the ovaries. And during that attempt, they can make lots of estrogen. Not always. Some women, go through months with making very little estrogen. But depending on the situation, there can be quite a lot of estrogen. There can also be estrogen coming from the fat tissue in PCOS. That's kind of a common situation as well. That estrogen will stimulate the uterine lining until it just reaches the point where it just sheds spontaneously. Like, it's not shedding because of a signaling from dropping progesterone. It gets too thick, and then it just starts flowing, and it wouldn't be a proper flow. Like, an anovulatory bleed often has spotting. Going back to our spotting question, that's another reason for spotting. And it would probably go on for quite a long time, like sometimes like a week or more, or 2 weeks, and it could be light or heavy. That could vary. So the best way to know, and surprisingly, women can have fairly regular anovulatory bleeds, which I myself didn't even realize until the last few years. There's a bit of research about that from a professor, an endocrinologist in Vancouver, actually, called Geraldine Pryor. Geraldine was great. If you don't know her, she would be a really good connection for you. So she discovered that a lot of women have anovulatory cycles. And also I'm seeing that in my own patients now that I'm kind of looking for that more carefully. And the way to know, so every woman you need to know whether you're ovulating or not. And there are really only 2 ways to do that. One is to track temperatures, looking for that shift, that slight rise in basal body temperature in the second half, not even the second half, but depending on how long your cycle is, in the last 10 to 14 days of your cycle, should be a temperature rise. And you have to use a proper basal body temperature thermometer or ovulation thermometer to check that. You won't see that with a fever thermometer, probably. And the other way to know for certain if you ovulated is with a blood test for progesterone. But of course, you're not going to be running out and having a blood test every month. But you might do one. I order progesterone blood tests quite often to try to understand that.
Okay, thank you. And
yeah,
so about PCOS, I know you have a post about the 4 different causes of PCOS.
Yeah.
So I know there's talk of a name change coming for PCOS. So if you were to name it, would you maybe split it up into the 4 different causes?
Well, yeah, into different. The new name there's going to be more than one new name. Absolutely. So the new name is going to be, I don't know what it is. I hope that they release it soon. It's going to be something about androgen excess. So androgens are the male hormones. So that's the key. That's the main part of the syndrome. So there can be androgen excess associated with because of insulin resistance. That's what I call type 1. There can be kind of a temporary androgen excess and failure to ovulate after the pill, which I call type 2, which is usually temporary. It's because of what happens with a pituitary hormone called LH that can spike up after coming off the pill in some women. I don't know that that's going to get a name. I don't know that the post-pill PCOS was kind of my observation, what I see, what I work with my patients. And then there's the non-insulin resistant PCOS, which is very often associated with inflammation, which is what I call type 3. So it wouldn't surprise me if the official name is an androgen excess associated with inflammation. There's also androgen excess, there's also, which isn't actually in that 4 types, but I wrote another blog post about it later. There's androgen excess from the adrenal glands. So there's also, in terms of PCOS, it's worth thinking about whether the testosterone, the androstenedione, the DHEA, the androgens are coming from the ovaries or from the adrenal glands. And that requires quite different treatment. I'll just say, finally, sorry to interrupt you. I know that the confusing thing about PCOS and why I'm praying for a name change is because it's not under currently we give the same name PCOS to, well, thousands, probably millions of women that are all have, there's groups, like they don't all have the same thing. Some of them have quite like a completely different condition and cause and everything compared to others. So to give everybody the same name of the condition means that a good portion of people are constantly pursuing treatments that don't work for them.
Right. Yeah, that's a good point. I think Geraldine Pryor actually calls it anovulatory androgen excess.
Okay.
That's kind of her name.
Anovulatory androgen excess. Absolutely. So you know her. Yeah, so that's good. So, yep, I think that's probably one of the contenders for the official name. And the other thing about the name, which your listeners need to know, that with the name change, we will finally we'll stop thinking about what the ovaries look like on ultrasound, because that finding of polycystic ovaries on ultrasound is not helpful. It's not diagnostic. It is not permanent, for one thing. It changes month to month. So as soon as you ovulate again, the ovaries are going to look completely different on ultrasound. So you can have PCOS and the condition, the hormonal condition, and have normal ovaries on ultrasound. Conversely, you can have what look like polycystic ovaries on ultrasound and not even remotely have the hormonal condition. So in fact, what they know now is about women with normal hormones, not PCOS, have polycystic ovaries at least 25% of the time if you were to ultrasound them. So it's, yeah, I look forward to the day when some of this confusion is removed.
Me too. Okay, so we'll just move on to some questions people have been sending in. So one was, are peanut oil and sunflower oil healthy like coconut oil and olive oil?
No.
Can you say
so
what?
They have a lot of omega-6. So there's different types of fatty acids, which are, if you think about it, so there's omega-6 and omega-3. What people know about omega-3 that you get from fish and grass-fed meat and eggs, and those, they're not just fats, they're actually signaling molecules as well. They go down a hormonal cascade, and that to prostaglandin cascade, and they become sort of signaling molecules in the body. And too much omega-6, we need some of it to be healthy, but too much of it creates inflammation in the body, and it's very real. And we are bombarded by omega-6. It's everywhere. It's in any vegetable oil, including sunflower oil. And I don't know the exact omega-6 content in peanut oil, but I'm not a fan of peanut oil. But we're already getting too much of it just from any restaurant food that we have. All the restaurants use a nasty vegetable oil. So if you eat out at all, then you need to be extra careful that when you're at home, you're having only oils that don't contain a lot of omega-6. There's also omega-6 in grains and nuts. So if you eat nuts, you're already getting as much as you need. Yeah.
Okay, and what about omega-9?
Yeah, I don't know much about omega-9 actually. Sorry. Yeah.
Okay.
Is that linoleic? Yeah.
Okay. So another question was, do spearmint tea and ashwagandha help for PCOS?
Mint has an anti-androgen effect, so it can help to block testosterone. I know, I've seen that in the literature and the studies. I don't prescribe that a lot myself, because I think there are better things. But okay, so that's mint. Ashwagandha is a great herb. It's that's also called withania. I primarily use it. It can help with production of thyroid hormone, which is beneficial for ovulation and potentially for PCOS. It also helps to modulate our stress response. So stress hormones have a big influence on women's hormones and on ovulation. So the short answer is yes, I think withania can be helpful. It's not one of my, in my book, it's not one of my herbal medicines targeted to PCOS, but it could be used. Yeah.
Okay, and another question we had was, is there any proof or validity for using yoni or jade eggs to help reduce period pains? Do you know what those eggs are?
I think you insert them vaginally? Is that what they are? Yeah.
Yeah.
Don't know. Don't know. Yeah. Don't have the answer to that. I haven't used them myself or prescribed them. Wouldn't surprise me. Like if it's working on this would be a question more for Barbara, I would think. It's working more on kind of pelvic floor, strength and tone, and yeah, that's yes. I think what's happening physically in our pelvic floor does affect our uterus and ovaries, of course. Yeah.
Right. So the Barbara that Lara was mentioning
yes.
is Barbara Loomis. So she has a blog, Alignment Monkey, or you can find her at nurturance.net. So I don't know if she has anything specifically about that, but she talks about a lot of structural things in pelvic floor health. So you can look there.
Yep.
Okay, and a question from Susan. So how do you feel about phytoestrogens in the diet for women with estrogen dominance or low progesterone conditions, especially endometriosis? So she says some practitioners recommend them, some advise against them. The lack of consensus is interesting.
Yeah, that's a great question. You're getting some, great questions from everybody. Thank you, everybody out there. Okay, first of all, I'm going to answer all the parts of that. I'm going to talk about endometriosis, estrogen excess, and phytoestrogens. Okay, so first of all, endometriosis, I will say, I just want to clarify around this. It is not solely the effect of, it's there's a lot more to endometriosis than just estrogen excess. And my latest blog post is about this. Endometriosis is an inflammatory disease. It's probably an autoimmune disease. It's my strategy for endometriosis is to treat the immune system and reduce inflammation. And I dive right into that. I don't worry. I don't look so much at estrogen, although I might, also as part of that, estrogen will come down naturally. But so that's endometriosis. But then in terms of estrogen excess, those would be conditions like fibroids, heavy periods, some types of PMS, breast tenderness, that kind of thing, irritability. That one of the most important treatments for that is to improve gut health and improve the effective detoxification and clearance of estrogen. That's the number one thing, because the gut bacteria are the organ that is, together with the liver, is most important for clearing estrogen. So that's often my focus. And I'll tell you right now, I often reduce dairy. Dairy is a big player in estrogen excess symptoms because of I think the way it creates inflammation in the bowel, and probably some things hormonally about dairy itself. But finally, the question was about phytoestrogens, which are plant molecules, I guess kind of plant sterols, if you will. They're not true steroids, they're not true hormones, that they're not estrogen, but they interact with the estrogen receptor. And they would be found in soy and flax seeds and legumes and lots of vegetables. And in short, they're beneficial. Like in a nutshell, they're beneficial for menstruating women because for anyone with estrogen excess, they're in general beneficial because they do interact with the estrogen receptor. They block it from the stronger estrogens. They're competitive at the estrogen receptor, and that reduces estrogen symptoms. It gets a little bit complicated because in other people, say children and men and women post-menopause, all those people have low estrogen normally. So then the phytoestrogens can have a net estrogenic effect because they're not competing with lots of normal, like lots of high dose estradiol or estrogen. So they end up having a stimulating effect on the receptors. So that's where you hear about things, and I agree that kids shouldn't be having a lot of soy milk, that potentially that's too estrogenic for them, that's potentially interfering with their hormonal balance. I don't like to give kids loads of soy. that's where you might say that, women post-menopause can get some, beneficial estrogen effect from phytoestrogens. So, and some of the phytoestrogens are stronger than others, and there's all different more subtleties to the question. But I hope that helped.
I think so. You can follow up if you have more questions, Susan.
Yeah.
So we had another question from Facebook. So someone said that they were looking for non-hormonal ways to help with cycle-related GI issues.
Okay, so that must be I'm guessing that's a premenstrual aggravation of irritable bowel syndrome or something like that, like a premenstrual or bloating or diarrhea with the period or something like that's common because of the local effect of prostaglandins on the digestion. That would be an example of what I talk about in my book as premenstrual magnification of an underlying issue. So if there's a gut issue, and this would be true for a lot of things, if there's headaches, or if there's a gut issue, or there's or joint pain, or something that's aggravated by the menstrual cycle, that doesn't mean that the menstrual cycle is in any way the cause of those things, because we do naturally, with different exposures to estrogen and progesterone throughout the cycle, different underlying conditions can get better or worse. But the solution is to treat the underlying condition. So that really, in my thinking, without knowing all the details of the case, that would come back to correcting the underlying problem. And if it's irritable bowel syndrome, for example, well, I would look at our understanding now of irritable bowel is that it's often linked to something called small intestinal bacterial overgrowth, or SIBO, and can benefit from sometimes the temporary removal of what are called high FODMAP foods, or foods with a sort of a lot of fermentable carbohydrate in them, together with doing a course of a herbal medicine to try to normalize the bacteria. That might be something like oregano oil or berberine, or and then possibly with a course of probiotics. That would be, and also start removing, not just removing FODMAPs, but potentially removing wheat. Well, the thing is, both wheat and dairy are FODMAPs, so they removing wheat and dairy almost always comes into it with digestion, at least temporarily.
Okay, great. And so another question we had from Facebook was, recently come off the pill and have been having various post-pill and inflammation PCOS symptoms, as I am lactose intolerant and have irregular periods. So I am due for a blood test, but what suggestions do you have for what I should ask my doctor to test for? And how can I naturally improve my symptoms, as my doctor has talked about putting me back on the pill, although I want to fix things naturally?
Yeah. Okay. That's my book. I don't mean to keep plugging my book, but
you give a lot of information in your book.
Yeah, so my book's called Period Repair Manual, and I wrote it in response to 20 years of questions like this from my patients. So, I know the questions, I know what happened. So hopefully some of the answers are there, but I will also answer the question. Okay, so how come off the pill, showing signs of PCOS, I guess, as in not having periods, or some breakouts, or potentially some facial hair coming through, I guess, would be the symptoms that there's no point in testing before at least 3 months off the pill. That's one thing I do with my own patients. I really think you need to kind of let your hormones speak, because your hormones have been completely suppressed by the pill. So you can't test them right away. You need to let them come up and sort of try to do what they're going to do, and then measure them. And the hormones, and I give a list in my book, but I'll say it here, it's worth getting, well, either baseline or on day 2 or 3 of the cycle, FSH, LH, estradiol, that's the main estrogen. Have a look at those. Thyroid, insulin. If there's any even question mark around PCOS, like even the slightest possibility that that's what it is, we need to be assessed for insulin. So I use fasting insulin. Blood glucose, just a simple glucose reading is not enough. That won't give you the story at all. You need to have either a blood test called fasting insulin, which the doctors would normally do, will do if you ask them, or you could, depending on what country you're in, you could pay for that yourself. And And there's another insulin test called HOMAIR index, which is one I'm using a lot more these days with my patients. And other blood tests would be critical. If there's any question of PCOS, you need to be tested for vitamin D. Vitamin D, zinc, thyroid. Did I say that already? This is to get the whole picture. Like, is it PCOS? Oh, androgen. Sorry, like you need to test for testosterone. The androgens I listed before, and that I list in my book and on my blog. You need to test for these to answer the question first. Is it really PCOS? Is that what we're dealing with? And beyond that, what type of PCOS? Like, is it insulin? Is it inflammation? Some of the other things that I talk about in my book. And prolactin is another hormone it's a hormone called prolactin that is a separate issue. It's usually not elevated with PCOS, but it's a common reason for lack of periods.
Okay, and this person's last question that I had was, what is your view on evening primrose oil for helping with hormones?
I don't use it. I'm thinking this relates to your omega-9 question, actually. Yeah, I don't. It's not one of my priorities. Yeah.
Okay.
Yeah. Okay. Sorry. No, omega-9. Sorry. Omega-9 is just monounsaturated. Yeah, so that's beneficial. So that's going to be in that's in olive oil primarily. Yeah.
Okay. Now, how do you feel about the path for women who want to conceive with insulin resistance PCOS?
Well, it's the same with everything I've just talked about. So if they want to, so it's about correcting the underlying causes of PCOS, whether that's insulin or inflammation, reestablishing a healthy, regular ovulation. And ultimately that's important for period health, but that can also be, obviously, that's critical for conceiving a pregnancy.
Okay, thank you. I was also wondering, can you have syndrome or whatever we will name it next, as well as functional hypothalamic amenorrhea? No, I wouldn't say. So your question is, can you have PCOS and HA or hypothalamic amenorrhea at the same time? Well, the problem is neither of them are very good, very precise diagnoses. So, for example, in both of them, there's some problem. Not problem. The hypothalamus is not signaling properly. So, arguably, the diagnosis of hypothalamic amenorrhea is really the diagnosis that they give when everything else has been ruled out, including PCOS. So if there's any markers at all of PCOS, then it's PCOS, according to our modern naming. But yeah, I'm actually hoping, I actually think even hypothalamic amenorrhea needs a better name, kind of a more precise classification. But in its truest sense, hypothalamic amenorrhea would be from being too low body weight or too much stress or illness, underlying kind of stressful illness. Yeah. Right, okay. One of the things I was discussing with someone else was that the importance of doing stress alleviating activities, and how some of these stress alleviating activities don't actually bring you into a parasympathetic state. Do you have any thoughts on like parasympathetic state versus a sympathetic state?
Not specifically. I mean, obviously stress reduction is important. I'm curious to know what you mean, like that some of them don't, because we don't want to be just purely parasympathetic either. Like some people are too parasympathetic, too much in that mode of their autonomic nervous system is in that mode. So I don't really think about it in those terms. I think about regulating the axis between the hypothalamus, pituitary, adrenal glands, and the nervous system, the autonomic nervous system, and just promoting good sleep. Often I think sleep is a good indicator of what our stress level is like, if we're able to sleep.
Okay, yeah. Well, I think that sometimes even when you're sleeping, you might not be sleeping at the deepest level possible for promoting the best recovery of your body. I can send you some things about that.
Yeah, send me that. Yeah, I don't look at it from that angle, but I'd be open to seeing something. Yeah.
Okay. Now, what is one of your biggest recommendations you say to people that have just begun their kind of menstrual journey? They've just had their menarche. What would you say to them?
Oh, like a 14-year-old, something like a girl. Oh, that's a very good question. Just that it's normal, that, it's a sign of health. It's a good thing. And if the girl is experiencing problems, then I would also, let's try to find ways to make it a bit easier, make the periods a bit lighter for her, less painful. Yeah. So that it's a positive experience.
Good. Okay.
Yeah.
Another question, what do you recommend for endometriosis pain that is a natural alternative to painkillers? So this person is currently changing their diet and taking supplements.
Yeah. Well, we talked about endometriosis a little bit earlier, about how it's primarily an inflammatory disease. That's how I'd classify it. That's how it's been classified. So, and pain is a key feature of that. So it's a whole body. It's not just about what to take. This goes for any kind of period pain, actually. It's not just about what you take during the time of the pain. That's not going to work at all for natural medicine. That's not how it works. It's about changing your body chemistry and reducing inflammation so that when the period does come, it's not painful. And if it is painful, then you can still, I don't mind, in the early stages, if my patients are still using painkillers during their period, if they need them, I don't want people to be in pain. But there are some of the supplements that we use. So one of the most important ones is turmeric, an extract of turmeric. It should be taken throughout the whole cycle, preventatively. But then it's one of the supplements that during the pain itself, during the period itself, it can be dosed a lot higher and it does work quite well, actually. It can work almost as well as, ibuprofen and some of the anti-inflammatories, and you can combine it with the anti-inflammatories. Yeah.
Okay, great. All right. So why do you think this conference needs to happen?
Because I'm excited about periods. This is a continuation of the year of the period last year, and just women and men. I'm hoping you get some men coming to your conference talking, because they have wives and daughters and friends.
I would say chances are someone with a uterus.
Yeah, chances are someone with a uterus. So it's just a chance to speak very openly. I love what you say about no stigma. Reclaiming this, kind of reclaiming what it means to have a healthy period, and how that's just a normal part about being human. So I'm really excited to meet, and I love the way you've brought in such diverse artists and activists, and it's not just about the health of the period, which is important, obviously, but it's about lots of different aspects.
Okay, great. Yeah, I'm excited.
Yeah.
I think even people that are focusing on menstrual health often neglect certain components of menstrual health, whether it's structural things and stuff. So I'm just really hoping to widen that spectrum. So
yep. The structural is important. Yep.
Another question we had was, what do you say about inconsistent luteal phase length?
That's about ovulation quality and progesterone production. So they go in that order. First, your follicles, your ovarian eggs or follicles, spend about 3 months moving towards getting healthy, getting ready to, then one of them finally ovulates. And that's how you make progesterone. And the amount of progesterone and the strength of it's called the corpus luteum, like the gland that forms after that egg ovulates, that's what determines how much progesterone you're going to make that cycle. So it's, as I said, it's our report card. So progesterone is, so the way to make more is to be healthy in all the different ways that we talked about.
That we've been going through. Okay.
Yeah.
All right, great. So, yeah, this person said that they've been tracking their cycles for 3 years with temperature and cervical
Yeah.
mucus.
Yep.
They're in their mid-20s and they ovulate regularly and have never used hormonal contraceptives. I'm jealous.
Oh, and there's still a short luteal phase. Is that the question? That all these things
Yeah.
that you just said, never hormonal birth control. I'm curious if we're live, I don't know if the person could say how many days
Well,
is
I don't think it
short.
wasn't
Yeah.
short. It was irregular luteal phase length. Like you seem to say that it's 14 days that the luteal phase should be
Well, between
exactly.
10 to, I guess, even a little bit more, like 15 or 16. 16 would be unusual to push past many days past 14, but it doesn't have to be like if it's falling in the kind of, let's say, 11 to 15 day range, that's normal. It doesn't have to be exactly the same every month. Like there might be some months when you're just super healthy, like your stress levels are down and you just had a really good ovulation and your luteal phase is a bit longer than it had been kind of in a normal, busy, stressful month. That's normal. That's a good thing. That I don't know if that's what she's talking about. That though, I don't know. It's just, if the luteal phase is dipping down, like is shorter than 11 days, 10 or 11 days, then 11 days, then that means something.
Okay.
Problem.
All right. Well,
Yeah.
as long as irregularity itself is not an issue within that range, 11 to 15 days.
No, and that goes for the period as well. It doesn't have to be spot on the same every day. I don't believe that. Because that's just not what the real world's like. Like we do have variables in our life, and some months are, a bit different, and that'll show up in a cycle that's a bit longer or shorter. That's okay. But it should fall within from day 1 to day 1 of the cycle, it should fall within 21 to 35 days, usually. Yeah.
Okay. One thing you recommend for people when either they don't have a period or maybe they notice that they don't ovulate is to look back 3 months. So
Yes.
should it be exactly looking back 3 months or just looking over the course of the last?
Over the course of the 3 months. It's like, what have the last few months been like, and how might that be expressing itself in my period now? Yeah.
Okay.
Yeah.
All right. Now, a last question we'll take is this person says, I loved your book. Do you recommend anywhere I can go to find further information on this topic in general? Notable books, blogs, websites, conferences?
Conferences for this blood cycle conference. There are lots of good blogs out there as well. We mentioned Geraldine Pryor, the endocrinologist. They have a site called the Center for Ovulation Research or something.
CEMCOR, right? So Center for Menstrual Cycle and Ovulatory Research.
Yeah, so they've got, and she did some studies. There's things on there. There's different blogs. There's a woman, Nicole Hardim, who I chatted with a couple times. She has a blog. What's it called? Like period fixer programs. So she offers different programs. Lots of, depending on your actual, there's certainly lots of blogs about PCOS and some of the more specific problems. Yeah, I hope that's helpful. I wish I should have, I need to prepare kind of a resources list of all the different people who's out there doing what. I'm sure I've left some people off the list that are doing really important things, but yeah.
It's hard to remember them all.
Yeah.
Yeah. Okay, well, if you guys found this helpful today, it would be so great if you could just pop over to our Kickstarter, just find Blood Cycle Conference, and you'll find lots of different perks that have, everything from Lara's book to other books on the topic, as well as some reusable pads from Luna Pads. So we really encourage you to go there, and you can also buy a conference ticket. So it'd be great to have more people kind of coming out for that. So the conference is September 3rd and 4th in Vancouver, Canada. So that's the Labor Day long weekend in the fall.
Yeah, It's going to be a great event, and I just encourage everyone to. It doesn't take much. If everyone just sort of gives a little bit, it'll push it over the finish line, and then we can all get together and talk about all this and meet everybody face to face, which would be really fun.
It'd be great. Yeah, I like to encourage people. Even if you just donate $1, $10, anything to vote for the conference to happen.
Yeah. To vote for periods.
Yeah, exactly.
The importance of periods.
Great.
Great.
Okay,
Thanks, Lana.
thanks so much, Laura.
Yeah. And we'll
Bye.
see you in a couple days for the Twitter chat.
Yes, exactly. So that is, let me see, that's on the 24th at the same time, so 3 p.m. PDT, and we'll be on Twitter with #PeriodRepair. So see you there.
Great. See you there.
All right. Bye.